Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launch of a joint NAMS-AIIMS PGIMER Navigate CME program for postgraduate students in all the AIIMS and other eminent institutions of the country. Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first and third Friday of every month from 3 p.m. to 5 p.m. The CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Thank you for your kind support.
Hello and good afternoon everyone to the next session of Navigate's Medical CME program. Today, before I begin with the topic, I would request Professor A.K. Sood sir for the welcome address for today's CME program. So over to you, sir.
On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and pleasure to welcome the distinguished speaker for this afternoon, Dr. Astha Thakkar ma'am. Thank you so much, madam. I am sure that the practical tips we are going to give about headache, which is a very common issue, I think it will be very, very useful to all of us, especially to our PG student. And we look forward for your session. Thank you so much for your support to the Academy. I also take this opportunity to extend my warm welcome to all the participants, faculty members, senior faculty member, dean directors, and our postgraduate students who have joined us in this afternoon. I wish you the season greeting because this is a festival season, but still you were able to join us. So if you have any query, question or remark, please put your question or remark in the chat box. Our distinguished speaker will be happy to answer at the end of the session. So once again, I welcome you all for this particular session. Over to you, Dr. Jaswant.
Thank you very much, sir. Since this time we are dealing with very, very important topic, that is headache, as mentioned by Professor A.K. Sood, sir. In order to begin, before we begin, I would request if we will listen to the messages from President, National Academy of Medical Sciences. And yeah, please.
My dear young colleagues, faculty and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
So thank you. Thank you, sir. So
Namaskar.
next,
Outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
since we all know that headache is a very, very relevant topic, and I would say that irrespective of any branch, no one can think this as relevant as any other. As Professor A.K. Sood sir mentioned that this is a festive season and the attendance is quite low this time. Sorry, ma'am, but uh, this will be recorded and this will be uploaded on the website. So thank you, ma'am, for being here with us. This is my turn to introduce our esteemed speaker for today's session. Ma'am is additional professor of neurology. Uh, Hello. Dr. Astha Takkar Kapila. Ma'am is additional professor in the Department of Neurology at PGIMER Chandigarh. Ma'am is also assistant editor and editor of various journals. Ma'am has special interest in neuro-ophthalmology, neuroimmunology, and neuro-oncology. Ma'am has numerous publications and book introduction. With this brief introduction and without wasting much time, I now hand over the dice to ma'am.
Thank you, Dr. Jaswant, and thank you the entire team NAMS
Thank
and
you,
all the and all the dignitaries who've allowed me this talk over here, I would say. Should I be sharing the presentation side by side?
Please, yes, ma'am. Yes, ma'am.
Just 1 second. So is my screen visible to you, sir?
Yes, ma'am. It's very well visible, ma'am.
Right.
And
So in
audible,
that
ma'am.
case,
Thank you.
yeah, in that case, if you allow me, I'll start the presentation as well.
Please, ma'am. Please, ma'am.
Thank you. So once
Thank you.
again, I thank everyone for letting me in this very prestigious forum. And thank you, Dr. Jaswant. And yeah, see the greetings of the season to all who are here and all who will be watching this online later on. It's an auspicious time, but nevertheless, I think this topic, headache that should alert a physician, is one of the very favorite topics of rather all the neurologists. Because of this phenomena, which we all know is the second victim syndrome. So what is the second victim syndrome? So one is that the first victim is the patient who's already suffering with something. And the second victim, we say, is the physician who, by the virtue of missing a diagnosis, suffers the pain, the crippling guilt, which is known as second victim syndrome. And why am I talking about the second victim syndrome here? I'm talking about it because headache is something with which 80% of our OPDs will be filled. So it's not just the neurologists who are seeing the headache, it's even the physicians, the surgeons, the dermatologists, the ophthalmologists, the ENT specialists. So all of us would have had one patient of headache each at least in our career. And all of us are only bothered about one thing, that we should not be ruling out and we should be ruling in rather the headache, which can be ominous to our given patient so that we may avoid the second victim syndrome or that crippling guilt. So with that, I think I'll begin this talk quickly. So this is the picture of a public awareness program which we had somewhere in 2024. It was named as Headache Alarms. And the first question which was asked to the entire audience was that, have you ever suffered from headache? And unanimously, I think the answer was yes. All of us have suffered headache one time or the other in our life. What is important is that which headache can I take lightly? If I am to be believed, I would say that no headache should be taken lightly, except the human versions of headaches, of course. But that's not the question in the today's forum. We are here concerned about the fact that what headache should be alerting a physician enough that one should undergo a scan or a referral to emergency department or a referral to a specialist or any further investigations and treatment. So this is again a very common question. So we see day in and day out patients who would come to us and ask, should I be getting an MRI scan? Should I be doing a CT scan? What investigations do I need for my headache? Are there any investigations which are needed at all for any type of headache? And the answer lies somewhere in this slide. So that's the first message which I would want to give you, is that headaches are broadly classified into primary and secondary headaches. When I'm talking about the fact that which is the headache which should alert any physician, I'm talking about a secondary headache, which means a headache which is due to a cause which I will be treating differently, except the primary headache. So now, what are primary headaches? Primary headaches are the disorders which are disorders in themselves. So they are independent, they have independent physiologies, pathomechanics, and they are not caused due to any other secondary cause. For example, like we all know, migraine, tension type headache, cluster headache, trigeminal autonomic cephalgias, so on and so forth. So when a patient comes to emergency, that's the first question in your mind. Do you want to send this patient for an MRI, CT scan, For that matter, do you also want to prick this patient for an investigation? So how do we find those answers is what this talk is about. And I'll be talking more so in an emergency perspective, because that's where, since the emergency OPD, it's the emergency ward where you do not have the luxury of time and you need to quickly think whether I should send this patient home or whether I should send this patient to the MRI console. So recognizing primary headaches is as important as knowing what are the causes and how do the secondary headaches look like. So let's talk in brief about the primary headaches. First, most common is migraine. So recurrent unilateral headache lasting for 4 to 72 hours, which is throbbing in nature, which may be moderate to severe in intensity, but is often associated with nausea, photophobia. Phonophobia is often a characteristic migrainous headache. As you can notice in this picture, it's usually hemicranial, but it can change sides, which means it can be on right side at some time, on left side on some time, and so on. What is a tension type headache? So as they call it, this is the area of tension type headache. So it is a typically bilateral, pressing, tightening headache, which is usually mild to moderate in characteristic. A sinus headache, again, this is the area of a sinus headache. So it's a facial pain. It's the frontal pain. It causes nasal congestion. It also can be throbbing, and it worsens on neck or head movements because of the flow of fluid inside the sinuses. Another important cause of primary headache is a cluster headache. Rather, I would label them as trigeminal autonomic cephalgia. As the name suggests, trigeminal. It's usually in the area of trigeminal. So V1, V2, V3, this area. It is usually very severe, usually unilateral in the supraorbital temporal region, and is associated with autonomic changes like conjunctival injection, lacrimation, nasal congestion, rhinorrhea, eyelid edema, facial sweating, meiosis, ptosis, restlessness, and agitation. So this is, ladies and gentlemen, the basic types of primary headaches. And I'll just leave primary headaches over here because primary headaches are rather the headaches which can be taken a little lightly and can be treated over a course of time. But what cannot be missed by a physician is a secondary headache. It's ruling out of a secondary headache when we talk about primary headaches. So that is very important to know. This is the small snoop mnemonic which we call for a secondary headache. Rather, it can be considered as red flag signs of headache. And you can see over here, the first thing is that history of any immunosuppression or malignancy or systemic features like fever, night sweats, myalgias, associated weight loss should alert you that you're dealing with something really systemic. It may also have some abnormal systemic examination. Neurological signs, any focal deficit, any seizure, any diplopia, any cranial nerve suspicion, this can be a secondary headache. A sudden and onset headache, a headache occurring in a very young child or in an elderly should alert you that this can be a secondary headache. A headache which was existing previously but has now changed its pattern, or which is a progressive headache. It is evolution, it's getting evoluted every time the patient comes to you. It's having aggravations like postural aggravation or Valsalva, increasing on Valsalva. So all these things will suggest you that it can be a secondary headache. Associated papilledema, headaches in pregnancy, headaches which are phenotypes of rare headaches like hypnic headaches, exercise headache, cough-induced headaches, sex-induced headaches should alert a physician that yes, this can be a secondary headache. So there has been an evolution of these SNOOP criteria or SNOOP red flags, as they would call it, over and over the time, again and again. And these are the additions which have been added. So any painful eye, any autonomic features should suggest that you should rule out secondary causes before you consider a primary headache syndrome. Headache occurring in patients with immune system disorders, headaches occurring in patients who are consuming excessive painkiller, which we call as medication overuse headache. All these headaches can be secondary headaches. I understand it's very difficult to remember all these types of secondary headaches in one go, but let's go one by one and see how these patients present to us and how we should deal with ruling out the secondary causes. More or less, you can see these broad categories. So once you're feeling that the patient may be having something vascular, patient may be having something to do with intracranial pressure, or you're suspecting an infection. Do remember, you have to rule out in all possibilities a headache, which may be a sign of an ominous disease. To begin with, first, if there is a patient who's come in emergency with a sudden onset severe headache, there has to be a ruling out of a thunderclap headache, rather, a headache which occurs within seconds, which peaks from its onset within a few seconds or minutes to the highest in intensity. This is known as a thunderclap headache. And more or less, thunderclap headache has been associated with the presence of blood in the brain. Rather, I would call it that subarachnoid hemorrhage is something which comes to your mind and you have to rule it out when a patient comes and says that this is the worst headache of my lifetime, which means it's a thunderclap headache. And what you have to be aware of is that it can lead on, or this can be a sign of subarachnoid hemorrhage. So that gets us to the first topic of vascular headaches. So let me share this interesting example with you. So this patient was a 40 years old neurosurgeon himself. He, while operating, had a new onset explosive headache during on the operation table when he was doing or performing an operation. He also had one episode of just a transient episode of loss of vision, again 7 days back when he was operating a patient, and he recovered over time. He thought that he would get MRI done subsequently, but here comes the knack. So he got a CT done. CT wasn't showing anything else, and before the patient could get any further evaluation done, within 5 to 6 days, the patient had another bout of thunderclap headache, and now this time he had a seizure. Not just a transient one, but he had a seizure followed by an altered mental sensorium. When he regained consciousness, he was having severe vision loss. And this is what was present, ladies and gentlemen. So this is blood all across the subarachnoid space. And what we could see on the angiogram was this aneurysm. The aneurysm was picked up when afterwards the patient has had a seizure, a subarachnoid hemorrhage, and visual loss. So what is important in this slide is that a sudden, intense, and a persistent headache may be preceding or spontaneous subarachnoid hemorrhage also by days or weeks. So in case there is someone who's never had a headache in his lifetime, but suddenly presents with the worst headache of his life, one has to rule out a thunderclap headache, one has to rule out a subarachnoid hemorrhage. So once you get an abnormal CT or an abnormal CT angiogram, you'll be very happy. But the point is, what if when you get a normal CT or a normal CT angio? So in case the patient is having a thunderclap headache, do remember that this warrants a CT angiogram. If a CT angiogram is also normal, but the patient has had one such thunderclap headache episode, it also warrants a lumbar puncture examination to see whether there is any blood or not. And in case you're doubtful of a blood, in case there's xanthochromia, in case it's abnormal, do know that you have to go, the patient has to undergo a digital subtraction angiogram to be sure that we are not missing on an aneurysm. So these patients can also come with other features. Fundus examination becomes important over here. So these patients may have vitreous, subhyaloid, subretinal space hemorrhage. Why? Because of the subarachnoid blood entering into the lamina cribrosa via the paravascular spaces, entering into the blood, into the retinal regions, entering into the subhyaloid space, and leading on to what we know as Terson syndrome with papilledema. So these are the 4 important things. Remember, worst headache of life cannot be ignored. Patient may be having some sentinel headaches. So even those sentinel headaches cannot be missed. Sentinel headache means the warning headaches which patient gets before actual event happens. Angiogram is a must. And remember, CSF examination if angiogram is normal, but your index of suspicion is high. What is important is how to also manage these patients. So blood pressure should be kept less than 160 in a setting of an unsecured aneurysm. Nimodipine can be used. We try to start treatment as early as possible and continue it till at least 1 month. Though prophylactic anti-epileptic drugs are not really required, but seizures, in case they occur, they ought to be treated promptly. Of course, the definitive treatment is surgical clipping and endovascular coiling. So now let's deal with this interesting example. A 60 years old female comes with sudden onset severe headache with altered sensorium 4 months back. And to us, she presents after 4 months of the sick terce when she has right itosis, which was not improving. Now, when the patient had headache at that time, she also noted that she was having right eye ptosis and blurred vision when she became conscious. And this is the photograph of this patient. So, keeping everything in nutshell, the patient had sudden onset severe headache with ptosis. So, if you can see over here, the patient is having a dilated pupil, which means ptosis with involved pupillary fibers, which means a pupillary involving third nerve palsy with headache. So this is also another red flag, and now we'll know why. Because in this patient, a CT was done at outside at a periphery, and it was reportedly normal. A CT angio was done again. It was reportedly normal. But what they missed was we went back and revised the CT, and you can see over here shreds of hyperdensity which are seen, which is likely because of some small bleed which occurred in this patient at that time. So there was some mild subarachnoid hemorrhage. And what is important is that when this patient underwent a digital subtraction angiogram, an aneurysm was sitting, causing pressure over the third nerve, causing a pupillary involving third nerve palsy. What is important for us to know is that the pupillary fibers, as you can see in this example, are placed outside in the outer area of the third nerve, like over here. In case the patient has a compression by aneurysm or by anything, the first things to be involved are these pupillary fibers causing internal ophthalmoplegia. So remember that headache with pupillary involvement should alert a physician that it may be a PCOM, which is a posterior communicating artery aneurysm, which is sitting on the third nerve conveniently and causing this symptom. Having headache in this scenario would suggest that the patient might have had some small bleed in that aneurysm. So this is just for your reference. This is the third nerve. Over it, you can see the posterior communicating artery. Underneath, you can see the superior cerebellar artery. In case there's an aneurysm, it is high likely that the patient would be having a pupillary involving third nerve palsy. So learning point is that you cannot miss pupillary examination in a patient who's come to you with headache. Now let's see this interesting patient. So a 38 years old male again presents with right-sided temporo-occipital headache of 4 days duration. Now this headache is also stabbing. The patient keeps popping in some painkillers but to no relief. Along with that, as you can notice in this picture, is that the patient is having some eyelid edema, some temporal edema, and some mild ptosis when the headache was worsening. And if you can notice over here, this pupil is smaller than the other eye pupil, which is supposedly normal. So what means that this patient is having headache, which is refractory to treatment, and this patient is having pupillary involvement in the form that the pupil is constricted, but the patient is not having any diplopia. There's no gross ptosis. So what is happening over here? Over here is happening what we call as Horner syndrome. So now you would recognize all the components. The patient is having meiosis, patient is having mild ptosis, and the patient is having minimal retraction of the eyeball as well. Having headache with Horner's should alert a physician. Why should it alert a physician? Because there is the sympathetic plexus which passes over the internal carotid artery before it reaches to the other areas. So because of this close communication of the sympathetic trunk with the internal carotid artery, one should suspect that there might be some dissection in this vessel when the patient comes to you with severe headache and involvement of the sympathetic trunk. So what is the learning lesson over here? The learning lesson over here is that in case a patient is having autonomic features with pupillary involvement, with headache, it should alert a physician that one should not miss an internal carotid artery dissection. And that's exactly what this patient was having. To show you, look at this tapering internal carotid artery. Look in the axial images that this patient is having this minuscule shaped area which is suggestive of a flap, which is the flap of a dissection. So a dissection ought to be ruled out in case a patient presents with headache and Horner's syndrome. Another interesting example. So this time it's a 22 years old female who has a history of migrainous headaches in past, but is pregnant in this visit. The patient is in the 32 weeks of gestation, and she has had a new onset headache of 15 days duration. Along with this headache, she's having vomiting. She's had one episode of seizure and altered sensorium, which gets her to the emergency department. What annoys us the most is that this patient should have been picked up at the stage when she was having only headache and no other feature, no seizure. Why so? Because this was a red flag in itself when a headache is occurring in pregnancy. All these patients should undergo a thorough investigation and at least a thorough clinical examination. So this was the examination finding. You can notice over here that the patient is having disc edema in both the eyes. And yes, what we could see over here is a big area of hyperintensity, which was blooming on the SWI images, which means there was hemorrhage as well in this scan. Why was there hemorrhage? Why was there an infarct along with hemorrhage? Because the venous sinuses, the transverse venous sinus of the left side, along with the entire venous system, was blocked over here. So now I think you'll be able to relate the symptoms. A pregnant patient coming with headache, with disc edema, what you ought to rule out is a thrombosis of venous sinuses, which we, of course, we know it as a CVT. Now let's see this another example. So now this is an 18 years old girl, was a recent travel to Nepal, and she has had multiple vomitings while she was traveling uphill. And she presents to us with new onset headache again of 20 days duration with some progressive diminution of one eye, the left eye, of only 5 days duration. So what pains us is that this patient should have been picked up 20 days back. Patient should have been picked up at least 5 days back when she started to have progression diminution of left eye. But this patient was not seen, and this patient was directly brought to the emergency department with one episode of focal seizures. So now what we see over here, now headache is occurring in the scenario that the patient has had multiple vomitings, likely dehydration. There was a history of travel to uphill, which means there was a history of likely increased ICP when the patient was traveling uphill. And yes, this patient was also having left cerebral venous sinus thrombosis, and you can see over here the infarcts which are already formed. You can see over here this empty delta sign, which means a thrombus is sitting inside the superior sagittal sinus, and that the left transverse sinus and further on the sigmoid sinus are all blocked. This is the fundus examination of this patient. If you notice over here, this papilledema, and I was talking about Terson syndrome some time back. So much of pressure inside the brain that the blood has leaked inside the subarachnoid sheath, entered inside the retinal layers, leading on to this picture of blood inside the retina, which we call as a Terson's syndrome. So what do we learn from these slides is that the recent history taking is very important. Remember, history of travel, history of dehydration can point out towards a venous sinus thrombosis. These patients, there should be a lower threshold of imaging. Pregnant patients, remember, in case a headache is occurring in pregnancy, you cannot just miss on the important causes of thrombosis, and that fundus examination is an extremely important examination in patients who are presented to us. So quick recap of the past few slides. Remember, what are sentinel headaches? These are warning headaches. So in case there's a thunderclap headache, do not miss on a vascular cause. Remember to see the pupils. Large pupillary involving third nerve palsy can be an aneurysm sitting in the posterior communicating artery. Small, it can be a Horner syndrome with headache, which means you have to rule out a dissection. Having focal neurological signs, having seizures, hemiparesis, imaging is, of course, must. Having painful autonomic symptoms, remember the sympathetic chain sitting over there, and this can help us differentiate between various important vascular causes like subarachnoid hemorrhage, cerebral venous sinus thrombosis, dissections, and acute hypertensive crisis. That gets me to the second topic of today's, the second part of today's topic, which is the basics. They do not change, and let's see why. So now this, I'm sorry. Now this is a 17 years old male patient. He is a NEET aspirant himself, and he was having headaches on and off for past 6 months. The patient was also having sleep deprivation, as his parents told. He's been studying all night. He has eye strain, he has a heavy head, and he has decreased attention. 6 months, they keep thinking that this is only the headache concerning his overwork or overstress or overwork whilst reading. Excessive screen time for that matter. But now the patient starts to have visual disturbances. The patient says that he is having visual disturbances, but the visual acuity is normal. So the doctor has a look on the fundus, and what do you see over here? Now let's just see this in little detail. What is happening over here? So you have disc edema, and along with this disc edema, you are having peripheral retinal vessel hemorrhages. These hemorrhages are interspersed. you can see these cotton wool exudates or exudation of proteinaceous compound in the retina. You can see these small whitish specks which are suggestive of some sort of a macular star. What is happening here? This is a typical fundus of a patient with hypertension who's been in hypertension or hypertensive retinopathy. So that's what it was. It was a hypertensive urgency. The patient's BP at that time was 220 by 160, and that was a surprise. 6 months, neat aspirant, but the BP was never checked. So what is important message in this slide is that a blood pressure examination should always take place wherever you see a patient who's having headache. Be it your emergency, your OPD room, or your ward, remember to at least check the blood pressure of this patient. I would like to tell you about the follow-up of this patient. When the patient was further worked up, he was having anemia. He was having HB of a hemoglobin of 8.5. Creatinine was 4.94. The patient had bilateral shrunken kidneys. The patient had gross left ventricular hypertrophy, meaning to say that this hypertension was not acute. This was a chronic, ongoing hypertension with an acute crisis. What is example in this slide is, remember, look at the disc and look at the BP. So your hand should be on pulse and you should be hearing a throb. Don't miss a bruit in such patients, and always look for a bruit whenever there is headache. Now, let's see another interesting patient. Now, this time it's a 44 years old male who's come to us with headache and a right hemicranial throbbing headache with nausea and vomiting. So you would associate this headache, this is very much looking like a migrainous headache, a hemicranial headache, nausea, vomiting, photophobia. But recently, the patient has had some change in the characteristics of his headache. This patient had intermittent increase. In the past emergency visit, the patient was treated with NSAIDs, beta blockers, amitriptyline, but the patient did not recover. Rather, for past 2 days, the headache started to increase, and it was associated with severe vomiting when the patient presented in the emergency department. Now, when he was seen, the vision was already low in one eye. It was 624. And there is the fundus for you. What's happening to the fundus? So if you see over here, right side disc is a pallid disc. There is pallor in the right side optic disc. And what's happening in the left-sided disc? There is disc edema. And what is this combination like? So one side pale disc, one side disc edema. This is typically known as a Foster-Kennedy syndrome, which means that in case there is an ongoing growing mass over one side of optic nerve, there is a high likelihood that that optic nerve will get damaged, leaving aside the pallor. And what would happen to the ICP, to the intracranial pressure? Because of this mass, the intracranial pressure will get raised, causing papilledema to the other eye. So this is known as a Foster-Kennedy syndrome. And this suggests that there is a mass lesion growing somewhere in close vicinity of one of the optic nerve, which is showing you pallor. So remember, optic atrophy in one eye with papilledema in the other eye is known as Foster-Kennedy syndrome, highly suggestive of a mass-like lesion. And that is what this patient had. You can see over here, there's a big mass lesion, big intracranial space-occupying lesion. That gets me to this other example. Now, this time it's a 21 years old female who's again had history of migrainous headaches in past, which has recently increased over past 5 months. And this headache would also increase during her menstrual cycles. But there was some recent change of headache. For past 5 days, she's having vomitings. And the vision is slightly reduced in one of the eyes. So that gets us to learning the art of examining the optic disc. Now, what's happening in the left fundus? It is almost like a hyperemic good fundus. Why have I put it over here? So that you may compare it with the right-sided optic disc. And now you may notice that the right side disc looks slightly pale as compared to the other side, the left-sided disc. Why is it important? It's again important because again this patient is having a compressive lesion, is having an intracranial space-occupying lesion. This is a sphenoid wing meningioma, and that is how you should know that in all these patients, fundus should be examined whenever they present to you with headache so that you may not miss an intracranial space-occupying lesion. 3 important things now again: fundus examination, BP examination, and searching for a carotid bruit whenever a patient comes to us with headache. Now let's talk a bit about headaches in special groups. So now look at this patient. An elderly patient who's had a new onset headache of 7 days duration presents to the OPD. While the patient was having headache 7 days back, after 2 days into his headache, he has diminution of vision of both eyes suddenly. When examined, the patient is having a negative perception of light in the right eye. Retrospectively asked, this patient also had some history of jaw pain, which was considered as was not very mundane by this patient, but it's only after losing vision in both eyes is that the patient got alarmed and presented. So before even I show you what occurred in this patient, what's important for you to learn is that any headache in an elderly patient who's presented to you cannot go without a few investigations which have to be done in these patients. And what are those investigations? In an elderly, remember, there should be examination of blood pressure, should be an examination of an ESR, a C-reactive protein, and preferably imaging. Why is it important? Because headache with vision involvement or even without vision involvement in elderly may suggest ominous diagnosis. For example, in this patient, now ESR in this patient was 90 millimeter per hour. The C-reactive protein was raised. The patient had normal blood pressure examination and normal temporal artery Doppler. So what's happening? Elderly patient having increased ESR with visual loss should just get you to a single differential, which is a giant cell arteritis. So remember to rule out giant cell arteritis in any elderly patient who presents to you with sudden onset increased headache, any form of visual involvement. In this patient, look at the fundus. There is bilateral pale disc edema. Left side is more pale, and the patient is having cotton wool exudates. Temporal artery biopsy was done in this patient. A history of polymyalgia and jaw claudication could be elicited retrospectively in this patient. And this is what temporal artery showed us. It showed us temporal arteritis. So intimal proliferation was there. There was break in the internal elastic lamina, and there was extravasation of RBCs inside of the tunica media. What is important? Elderly, new onset headache. Do not miss on a temporal arteritis. Remember to write in your examination file to do a CBC, a ESR, a C-reactive protein, and an ultrasound of temporal arteries. And in case you are still in doubt, go ahead, do a nerve biopsy or a arterial biopsy, as the case may be. So why am I interested to show you another similar patient is because in this patient, because of the awareness of a physician, vision could be saved. A 68 years old male presents with a new onset headache of 2 days duration. And this time, this patient is having only one episode of transient loss of vision of both eyes. Within 4 hours, the patient is rushed to the doctor. By that time, he had regained his vision. But because it's a headache occurring in elderly, and there was history of a neurological symptom or maybe a neuroophthalmic symptom, the patient was worked up thoroughly. The patient had history of jaw pain, of polymyalgia, an ESR of 104, and a raised CRP. And look what you can see over here. This is the prominent temporal artery in this patient, which was good enough to give us a clue that we went ahead with a temporal artery biopsy, and there was temporal arteritis. This patient was started on steroids, and the vision was saved for times to come. So this is again the PET scan of this patient. This PET scan also is showing you metabolically active region around the vessels, so temporal arteries, along the other larger vessels also, again giving you an indirect clue that yes, there was some sort of a vasculitis going on around these vessels. Another important aspect is the headache which occurs in patients with other diseases. Now, this elderly patient had history of idiopathic Parkinson's disease and was on levodopa. Now, this patient presents to us with acute onset headache, vomiting pain, and mild redness in the right eye. So it was initially thought that the patient might be having some mundane headache because the patient was also having cataract of the same eye. But when the patient lost vision, when there was no, when the patient had excessive vision loss along with headache was when the patient came to our attention, ESR was raised, CRP was normal. ESR was raised, but was not very raised. It was not more than at least 50. So it was 24. And the temporal artery Doppler was normal. So as I've just mentioned, any headaches in elderly cannot be taken lightly. We send this patient for a complete ophthalmic examination, and here you have this intraocular pressure which was 52, very high, and the patient had a shallow anterior chamber of the left eye also, the other eye also. Message is that glaucoma is itself a cause, and acute angle closure glaucoma is in itself an important cause of headache. So whenever you have subtle signs, remember some visual loss, some mild redness of right eye, headache occurring in any special group, you ought to have a possibility of glaucoma at the back of your mind. So in this patient, we postulated that because this patient was on dopaminergic drugs, so other drugs can also precipitate glaucoma, which we should all be aware of, like atropine, like nebulizer, prapropium bromide. So these histories should alert a physician to rule out other causes of headache, like in this patient, it was acute angle closure glaucoma. Another elderly patient. Now, this is a very common scenario with the patients who come to us with headache. Now, this is a patient who was already on dual antiplatelets and has had a new onset headache for past 1 month. And the relatives, so the relative was a nurse herself. So the staff nurse, she herself got this patient to us because this patient was having some behavioral changes for 15 days. So the headache was getting ignored, but because of behavioral changes is what the patient came to us with. The blood pressure was normal. And it's a very common scenario. What we saw in this patient, we got a CT done and there were 2 small subdural hemorrhages sitting over there. What is important over here? When we went back and asked the history, the patient retrospectively told us, yes, I got hit on the corner of the head of the, so my head hit the corner of the bed around 1 month back, after which I started to have headache. What is important to notice that in these patients, because there is a baseline atrophy of the brain, there is no major vascular support, and it's easier for those vessels, the middle meningeal vessels, to bleed and lead on to subdural hemorrhages. So the patients who are already consuming antiplatelets, the risk further increases a little. So remember that subdural hematoma or epidural hematoma can occur in these patients, especially elderly, even with minute traumas. You need not have major traumas in these patients. Remember that these patients may also have a lucid interval when the blood is collecting before the headache starts to occur. So they may have a lucid interval up to 15 days, 1 week, 2 weeks, 10 days. These patients may have atypical presentation because they already have an atrophic brain which can accumulate up to 30 ml of blood before the patients would start showing their symptoms. So you should have a lower suspicion, and you should remember that even a delayed imaging is important. In case you've got a CT done right now, patient's headache is continuing, you need to think that the patient may be in lucid interval and you need to have imaging repeated. So imaging after head trauma, should all these patients undergo imaging? So ideally, any patients who's having any red flag, like a low GCS, like a focal neurological deficit, any vomiting, any amnesia, or even if the mechanism of injury is a dangerous mechanism, if an elderly undergoes trauma, in case there is any local site bleed or a history of bleeding diathesis, these patients should undergo any imaging to rule out ominous causes. Now, the second special group is pregnancy. Now, in this primary gravida patient who's 25 years of age, there is headache of 15 days with diminution of vision of both eyes, with altered sensorium and seizure of 1 day. Why am I showing this example? Because this is again a very important example in our gynae wards. This patient was having a blood pressure of 150 by 100, urine albumin was 2+. Yes, this patient was having eclampsia. And why is the history of eclampsia with headache important? Is because these patients may be having posterior reversible encephalopathic syndrome. What is this? Now, posterior reversible encephalopathic syndrome occurs because autonomic nervous supply to the posterior part of brain is known to be not that well robust, because of which metabolic changes like changes in blood pressure recordings or a certain drugs may lead on to the failure of the autoregulation and hyperintensity and vasogenic edema, causing infarcts in the posterior region of the brain parenchyma. So it's an important cause of headache with focal symptoms in pregnant patients, and this should always be ruled out. So headache in pregnancy, headache in elderly need a very watchful evaluation. Another pregnant patient with headache. Now this 29 years old primary has history of migraine in past and is 2 days postpartum and develops bilateral visual loss, which is associated with thunderclap headache over these 2 days after she delivers a healthy baby. Now, of course, a thunderclap headache, some visual loss, this patient ought to be evaluated. And what did this patient have? This patient had bilateral vertebral artery dissection, as you can notice over here. And we should remember that dissection can itself be a forme fruste of reversible cerebral vasoconstriction syndrome, which may present in patients who are postpartum or pregnancy. So the message learned over here is that you cannot ignore headaches in pregnant or postpartum patients. Now, another example. Now, another 22 years old lady, primary gravida on 28 weeks of pregnancy, has headache for past 15 days, as luck would happen. This was one of my relatives who had called me up from a far distance in a very far off village in Punjab. And because the patient was a primary gravida, there were some leading questions which were asked. And one of the important leading question was, do you have any blurring of vision? And then the patient was like, yes, I feel that there's some mild blurring, but I can see everything. And that is what was there. So vision was normal. The fundus examination was normal. But when we heard this history, headache, with some doubtful visual loss, the patient was immediately rushed in for a visual field examination. And you can see over here, there is a bitemporal loss of vision. So you can see over here, temporal sides of both the eyes are showing losses. So this is a typical bitemporal visual loss. Why is it important? It's important because we all know how the optic nerves come, they cross, form the chiasma, and then go into the optic tracts. What is important, in case the patient is having bitemporal visual loss, it is a very specific localization towards these fibers, which are the nasal fibers, which are the fibers which may lead on, if the involvement is there, which may lead on to the bitemporal visual field loss. And what other anatomic structure is in this area? So that other anatomic structure is the pituitary gland. And in case a pituitary gland is getting affected during pregnancy to cause headache and field loss, what is the phenomena? The phenomena is that of a pituitary apoplexy. So that gets us to the examination, importance of examination, importance of knowing the importance of visual field examination. So this patient was immediately called. The patient was immediately operated for this pituitary apoplexy, and you can see over here the result. So there was a complete improvement of the visual field and headache in this patient within 7 days of the patients having these symptoms. So what are the important points now? Headaches in elderly, in pregnancy, in puerperium, in postpartum stage are all important for us, and they're supposed to alert you. You always to do ESR and CRP in elderly patients. Remember to retrospectively go and ask history of polymyalgias, of jaw claudication. Intraocular pressure examination is as important. And do remember, visual loss and loss of visual field are both important when a patient is having headache. Very quickly, now this is another 34 years old female who's had headache after for past 3 months, and look at the characteristics of this headache. So now in this patient, the patient was having headache after the patient would be sleeping. So which means the headaches were awakening this patient up from sleep. The headaches were associated with transient visual losses, and there was gross papilledema in both the fundi, despite the fact that the patient was having a normal vision. So MRI of this patient was done, and they were suggestive of a very tortuous optic nerve, of the flattening and rather indentation of the globe. All of this is suggestive of an increased intracranial pressure. So this gets us to another important part, that how does a headache of increased intracranial pressure would look like. So any early morning headache, any headache with projectile vomiting, any headache with transient visual losses, any headache with papilledema, any headache which increases on change of posture, on doing well salva, associated with pulsatile tinnitus, or with spontaneous CSF rhinorrhea, may be suggestive of increased intracranial pressure. So once that is there can be actually any cause of an increased intracranial pressure. There can be hydrocephalus, there can be a mass lesion, there can be a ventricular compression. But in our patient, the MRI was only suggestive of features, indirect features suggestive of increased ICP without any mass lesion. And this is what we call as idiopathic intracranial hypertension. The vision is usually spared in these patients. Why so? Because the peripheral retinal fibers are the ones which cross the optic disc at the periphery. It's only the central macular fibers which travel to the center of the optic nerve, which means in case there's any edema over here, it's the peripheral fibers which get involved first, leading on to peripheral field constriction, like you can notice over here. Subsequently, in case the edema will keep increasing, the visual field will get worsened, and the patient may end up with a complete visual loss. So in case there is so much of an increase in intracranial pressure that the fluid is seeping inside of the retina and reaching macula and causing this macular star-like picture, is when the patient would anyways have a complete visual loss Commonly, it is more of a field loss which occurs in these patients. So this just gets me to this important topic that one should always know what is the different type of disc edemas. So remember to look for hemorrhages, to look for cotton wool spots, to look for exudates, to look for blood, and they can all point out towards a different diagnosis. In case you get flame-shaped hemorrhages, remember hypertension. Associated with cotton wool exudates, remember vasculitis. Only edema, may be a mass lesion sitting up there. Blood, rule out. Hypertension, rule out. Subarachnoid hemorrhage, rule out. CVT. Why is it important? Because usually it's a peripheral field constriction. But in case there is a sudden increase in the intracranial pressures, these patients might present to us like this. So this is a 24 years old patient, 2 weeks history of headache, 2 weeks history of transient visual obscuration, which means headache suggestive of increased intracranial pressure, and only 1 week history of losing vision, which means now the patient presented to us with complete loss of vision. So in this patient, all the signs of indirect increase of intracranial pressure were present. There was nothing else found in the brain. So yes, this was a fulminant idiopathic intracranial pressure, which led on to visual loss in this patient. Also remember that while increase in ICP can cause headache, even decrease in ICP can cause headache, but the characteristics are different. So what does a spontaneous intracranial hypotension headache looks like? So a hypotension, an intracranial hypotension headache is usually an orthostatic headache, which means the patient complains of headache when the patient gets up. So at that time, there's a sudden pulling type of a sensation and the patient gets up. The moment the patient will lie down, the headache will disappear. So there are common causes of spontaneous intracranial hypotension, the commonest being an old trauma. So once there is a leakage, a spinal CSF leakage or a leakage anywhere, these patients may have spontaneous intracranial hypotension and headaches, which are related. So both increased and decreased intracranial pressure headaches are important to recognize and to treat. So now let's see at times when we get really confused. So what you should definitely not miss in an emergency department. So a 25 years old female presents with fever, headache, altered sensorium. So you all know you should rule out a meningitis-like headache. This patient is also having headache, which is early morning, which means there was some increase in intracranial pressure. And of course, imaging is done. And what can you see over here? You see hydrocephalus. You see lots of exudates. And yes, this was a patient of tubercular meningitis. You notice over here, patient had a prominent weight loss and loss of appetite. Another patient, again headache with fever, vomiting, diplopia. Why is there diplopia? Because there is a cranial nerve palsy. The patient is not able to abduct the left eye fully. There is a left lateral rectus palsy and there is full of exudates. So these again diagnosed as tubercular meningitis. You notice over here the patient is given ATT, and after receiving ATT, 2 months after, the patient again comes with visual loss. Why? Because in patients with tubercular meningitis, you may have an immune reconstitution-like presentation where the arachnoiditis increases if you do not give steroids along with. So a chronic headache with some low-grade fever, remember, tubercular meningitis cannot be missed. Imaging is a must. Also is must a CSF examination. And in case you are starting ATT, do not forget to add on steroids alongside. So this was just a gross differentiation of tubercular meningitis versus a pyogenic. A pyogenic usually has a more dramatic presentation within 1 day. But a tubercular meningitis may have a longer presentation. Patients may have weight loss, long-standing diplopia, and you also know about the CSF manifestations in this patient. A tubercular meningitis is likely to have comparatively less number of cells, maybe in hundreds, in the CSF, as against a pyogenic meningitis, which can have a heavily raised protein, a very low sugar, and cells which may go up till thousands as well. A 17 years old female, type 1 diabetic, presents again with headache, swelling, ptosis of one eye. Now, this history is good enough for us to think of a cause. So a diabetic patient coming with headache and local ophthalmic symptom, remember that a fungal infection ought to be ruled out, and we saw plenty of them during COVID. So any immunosuppression, including diabetes, should alert a physician to rule out a fungal a fungal etiology going inside the brain. Now, this is a very important and interesting patient. Now, 34 years old male presents only with one history of a seizure-like episode. There was no neurological deficit. The resident notes over here that there's a small calcified granuloma sitting over here on the right occipital lobe, and the patient is thought to be having neurocysticercosis, was started on albendazole with anti-epileptics. But what happens next? The patient, after receiving anti-epileptics and albendazole, comes after 6 hours with severe headache, and within 2 hours lands up into deep coma. Within next 8 hours has decerebration and gives up. What happened in this patient? What happened was this. So remember that in patients of neurocysticercosis, in case it's a neurocysticercosis causing multiple lesions, so this is almost like a starry sky appearance. In case albendazole is given without steroids, these patients may have an exquisite response, of breaking down of the NCC-like particles leading on to excessive edema. In this patient, this excessive edema led on to herniation of the brain. So what is important learning lesson over here is that patients of neurocysticercosis always remember to put steroids along with albendazole if you want to prevent these type of ominous presentations. Now, next is just the last presentation and the last message which I would want to give. This is a 48 years old female who had a headache, which is right-sided, sudden in onset, and frontal in characteristic. So this was a very sharp headache, and the patient almost presented to the OPD screaming at the top of her voice. At one moment, it felt that this patient was having a pseudo seizure-like episode when she was screaming at the top of her voice inside the OPD, which means that the patient was having a headache whose severity did not know any boundary. However, the patient, because she was having such severe headache, on day one, a CT is done and a CT angio is done, thinking that this was a thunderclap headache, but it was normal. Eye examination, including intraocular pressure, it was normal. Day 2, MRI was done with MR venogram. Both of them were normal. So what did we miss? We missed that on the day 3, when the patient presented to us, on the day she was planned for a digital subtraction angiogram, is when she presents to us with these lesions. So what are these lesions? So these are herpetic lesions. So what do I mean to say? That this can be a master mimicker, and a zoster-like herpetic lesions may appear over a course of time in patients who present with severe headache as well. So it's important to know that even herpes may cause that type of headache. What type of herpes causing headache is zoster ophthalmicus, and there have been various reports describing the various presentations in these sort of herpetic ophthalmicus-like presentations. So I would want to conclude with these few points which all of us should remember. So remember, fundus examination is of extreme importance. Pupillary examination, small or big, holds its own importance. Blood pressure and pulse examination is something which no physician can ever miss. Elderly patient, remember to always write ESR and CRP when they have headache. Any type of systemic or neurological sign is very important for us to rule out an ominous cause. And remember that patients who are pregnant or postpartum, their headache itself requires a watchful observation. So that gets me to the last slide of my talk. Thank you very much, all to the speakers and to the organizers for having me to this very august forum. Thank you.
Thank you very much, ma'am, for the wonderful presentation, especially the case vignettes, ma'am, that you discussed. And they make this presentation very interesting, ma'am. And like, it's easy for the participants to learn, and like, mainly for the application purpose, I would say. So it's useful for all the branches and all the medicos, I would say. Since we all know that, and we all have heard this phrase, that eyes are the windows to brain. So you, ma'am, presented the neuro-ophthalmic part of headache like very beautiful. And since majority of the causes, like some signs or some indications are visible over fundus examination, or maybe the vision only.
Yes.
So right. So ma'am, I just want to ask, like, this is my query, because before I begin with the query, which was there on YouTube.
Yeah.
So like, for all the causes of organic causes of headache, do the ophthalmic examination, like fundus examination and this visual acuity, are they sufficient?
Yeah. So I think, thank you, Dr. Jaswant. Thank you for your comments. Importantly, I think any patient who comes to the OPD with headache needs to undergo at least two basic things. One is blood pressure examination, and the second thing
All right.
is a fundus examination.
Right. Right.
At least when the patient is himself considering that, I have some visual problems, I have intermittent loss of vision, I have difficulty in viewing, these are good enough signs to get this patient examined, especially when the patient is having headache alongside. On this note, I will just want to mention a small thing. There are many young children who come to us with headache, and the very, very common diagnosis we make in them is a refractive error. So something which is as common as a refractive error often gets missed if you do not provoke and examine for that. So it's hardly a time I remember most of the young children, they don't go to an ophthalmologist first. They come to a physician or they come to a neurologist first because they start having headache because of that uncorrected refractive error. So in short, yes, BP and fundus examination should ideally be done in all patients who have headache at any time of life.
Right. Thank you, ma'am. Another question is from Dr. Rahul. Like, since he's preparing for the PG entrance, so he's mostly troubled by the questions in last year questions. Most common cause of headache. It keeps on changing in various books, and also most common organic cause of headache. So he just needs a guidance, please.
Yeah. So I think practically speaking, the most common cause of headache would vary with the patient profile. It's a young child, it is refractive error, it's an elderly or an adult person, blood pressure monitoring or hypertension is one of the most common causes of headache. So after you've ruled this out, then starts the other story. So I think these two things, depending upon what the question is, what does the question mention? Does it mention a 4-year-old child or 10-year-old child? Or does it mention a young adult, a 30 years, 20 years adult, and an elderly? One of the most common headache which you should not miss, again, is giant cell arteritis. Do remember that. So,
thank you, ma'am. I request the participants again to type their questions in the chat box.
Yeah, madam, excellent presentations and good clinical case discussions. Most of the things you have covered, except the functional component. How does a functional headache, which you have not touched up?
Yeah. So, sir, I think once you have ruled out all these things, the patient can be thought of having a functional headache. And nowadays, we no longer use the term functional that often. So it's either there's one or the other cause to any so-called psychiatric presentation of the patient. So many a times there is a mental stress, there is a tension type headache, which I just described. So once we have ruled out practically everything, we can label the patient to be having a non-organic cause of headache. And maybe that's how I would want to put it. Once we have ruled out all organic causes, only then we should consider a non-organic cause. The reason being because for most of the other non-organic focal neurological deficits, there is a pattern. For headache, usually there is no pattern. So the patient may have a localized nummular headache only in a coin-shaped area, headache only in a vertical area, headache only in a trigeminal area, or hemicranial area. So there are practically all sorts of headaches which have been described. So after first you have to rule out a secondary headache, then you should think whether the patient can be fitted into one or the other type of primary headache. If not, patient should always be treated for at least one type of primary headache so that we are sure that there is no primary headache which is being missed. Only then we should think of a functional headache and try to search for a non-organic cause or a psychiatric comorbidity, sir.
A headache with science is easy. Headache without science is a problem. And that too, of course, yours is a tertiary care. Everything is possible and you will do all the workup. But even within 1 hour, 2 hours, patient will come to the OPD. Headache without symptoms, without science.
Yes, sir.
So these are the challenging. So in what way, like for example, acute MI will evolve within a span of 3-4 hours.
Absolutely.
So how much is the window period, waiting period for headache to observe and send the patient back home?
Yes, sir. So I think that's the reason why I talked about these these secondary headaches. So examination, if it is fine, which includes also an intraocular pressure in elderly. So few things which ought to be examined in all these patients in whom we are not finding anything. First, to begin with, is the blood pressure, examination of the bruit. visual acuity examination, examination of the fundus, and intraocular pressure. So at least these 4-5 things. In case the patient is above 50 years, ESR and CRP have to be written. If these are also not found, and the patient is having a refractive headache, only then the patient should be sent for imaging. Otherwise, in case there's no other sign or symptom, there is no need to send the patient for a scanning or for even a CT scan for that matter. The patient can be sent home after giving a local NSAID, at the max, some beta blocker, thinking that the patient may be having a new onset migrainous headache. History of sleep should always be asked, because that might help us point out towards a functional type or a non-organic headache, though many a times primary headaches may also cause disturbance in sleep. Once all this examination is normal, I think the patient can be sent back home with NSAIDs and with some primary treatment of maybe a primary headache. In case the patient keeps having headache for at least 2 weeks duration, and the patient is maybe having evolution in the headache, the patient should be imaged. I think that's how I would see. In case the patient develops a new focal deficit over next 24 hours, he should always be cautioned. We always write it in our file that in case there's any new symptom, you need to report to emergency there and then. I think that's how we can approach these patients, sir.
The other commonest being fever with headache, 1 hour,
Yes.
2 hour fever, headache.
Yes.
Nowadays, dengue headache, so many encephalitis,
Yes.
herpes, this thing and all. Everything is normal, no signs.
Yeah.
Only fever, headache is there. Patient cannot afford for further investigation, neither a CT nor an MRI nor this thing.
Yes.
In outpatient setup, if postgraduate is sitting,
Yes.
what are the things he should be
Yes.
aware? When he
I
should
think
subject for those patients for investigation, when he should admit, when he should send him back home.
this is a very important point which you have raised, sir. Thank you for raising this. So often fever with headache is one of the most common presentation. In case there is, I'm repeating, so in case there is no focal deficit including fundus and the patient is having fever alongside, we should wait till the time fever settles. In case the patient is still having fever and the headache is occurring alongside, that is anyways an indication for an imaging. However, if the fever settles and the headache settles with it, there is no need of doing anything. So what one can view it as, in case patient is presented with fever and headache, patient should be treated for fever. When the fever settles, at that time one should be examined or should be told that please note that whether you are having headache at that time. In case there is no headache, the patient can be just treated for the primary viral illness. The patient needs not to undergo imaging. We should also remember that viral illnesses like dengue are themselves associated with some secondary causes of headache. So patient should be just made aware. So any purpuric spots, any blood, any melena, any external sites of bleed in case they are occurring and the patient is having headache, then we have to rule out a subarachnoid hemorrhage or an intracranial bleed, sir. Otherwise, if there are no other symptoms, we should not press the panic button.
The other thing being, since it is a tertiary care for your centers, now are there any genetic predictors to say that this patient is going to have, that this patient high risk for subarachnoid hemorrhage? So are there any genetic markers or anything which recent development which are coming up?
Yes.
Now,
Again,
because it's an era of precision medicine now,
absolutely.
so we have to be very focused and specific to the patient to answer.
I thoroughly agree with what you are saying, sir. And again, thank you for bringing that very important topic. So the patients who have had subarachnoid hemorrhage, we've been looking at these studies concerning with their blood investigation and the genetic profile of these patients. So there have been various proteomic studies which have been done and which suggest, I don't remember offhand, but there are various markers which can help us assess that a particular patient will be more prone for an aneurysmal bleed than that of others. So of course, we have also, I'm also a part of one such study in which we are also trying to study the aneurysmal wall to see that why a particular patient has had a subarachnoid hemorrhage, whereas others just keep keeping this aneurysm intact for years altogether. Though there are markers, genetic markers, but their practical use is very difficult to establish at this given point of time. But I'm very sure with the way science is progressing, maybe another 5-10 years, we'll be having some indirect blood markers, which may suggest that a particular type of mutations increases the risk of aneurysmal bleeds in a certain set of patients, sir.
Particularly in pregnancies and all, it will be helpful a lot for pressing this thing.
Yes,
Markers.
sir. Yeah. Yes, sir. Especially in special age groups. You're absolutely right, sir.
Another thing is nowadays the screen time.
Oh, yes.
Commonest cause for headache, screen time. How much is your screen time? 8 hours, 6 hours. History of screen time is very important to ask for all.
So we recently did a public survey after we saw a couple of patients, young patients, who developed accommodation spasm after excessive screen time. So because their accommodation was being continuously used, we did it during the COVID time and then we followed it up. And what we noted was that in children who are using close screen times, close screen images like mobile phones, in those patients, it was extremely common. Rather, they also developed accommodation spasm. So we did a couple of publications on headaches associated with accommodation spasms, especially in young children with premature or immature development of their eyeballs. So you're very right, sir. I think screen time and exposure to the light is a very important thing which we need to ask.
Another last thing in headache in elderly people, because they're everything because of some Parkinson's, so many other dementia, restless leg syndrome.
Yes, sir.
So dry eye, a lot of indirect things are there. They present mainly with headache. So
Yes,
everything is normal. How to proceed with those patients?
yes, sir. Sir, so I just mentioned one dictum which I have learned in my years in PGI all these years, is that whenever an elderly patient comes to us, even if the patient is not having any other symptom, four things rather ought to be done. BP, intraocular pressure, third is ESR, and fourth is CRP. If four of these is normal, you can wait after giving the primary treatment. If any abnormality in these four tests, the patient should be further investigated and imaged, sir. That's a very important question because I keep telling all residents, elderly patient cannot go back without you writing ESR and CRP on your examination sheet. So that's a very important point, sir.
So other last thing is in the primary setup, they get affordable only for CT. Beyond CT is very difficult. MRI, diffusion, these things and all, DSA. So there are certain in terminology like CT disappearing lesions.
Yes, sir.
So
Yes.
only one picture, one thing, suddenly starting anti-epileptic drugs or
Yes.
subjecting, are we justified, or we have to wait for 4 to 6 weeks, stop
Yes.
anticonvulsant, subject him for further evaluation, or what?
Yes, sir. Sir, so the CT disappearance of lesions often occurs because the indirect signs they disappear. Like I just showed one example of a neurocysticercosis. So many a times there is a lesion which is just in its development and it may be isodense at that time. But because that lesion has suffered an injury, there is a vasogenic edema which we see on CT. So we are not seeing that lesion on CT, but we are seeing the edema. And as that edema settles, that image almost again becomes isodense and we no longer see. So I think a clinical profile would really matter at that time. But whenever in suspicion, I think a MRI should be done for once the patient has had a focal deficit-like illness. So if it's a single seizure, maybe we can observe the patient. But if it is not a single seizure and the patient has suffered seizures twice also, or the patient is having seizure and is now having headache alongside, which means that something is going on which we are missing at the given moment. So I think the threshold to imaging will be decided by the fact that how a patient is responding to a treatment and whether or not the patient is showing any evolution of the symptoms. In case there's no evolution and patient is non-progressive, there's no new symptom, I think we can wait. There's no hurry. But in case there is an evolution, we should not be leaving such patients, sir.
Okay, thank you, madam. Thank you so much.
Thank you very much, sir. Thank you for your insightful questions, sir.
Thank you, Sangram sir, for making the session interactive and asking the interesting questions, sir. So, if there is any other participant, they can just raise their hand. We can unmute them and they can ask the questions. Despite being low attendance, ma'am, the discussion was very interesting, so very interactive. So it was good. Since ma'am, we do not have any further questions, so now I would request our Deputy Secretary of National Academy of Medical Sciences, Professor A.K. Sood, sir, ma'am, for the word of thanks. Over to you, sir.
Thank you, Dr. Jaswant. I think it was a very nice presentation, one of the best presentation in this series. Thank you, ma'am, for giving us that overview of headache, especially the way you presented the cases. I think all of us, especially our participants, have greatly benefited. So thank you so much for your support and a blessing to the Academy. And we look forward for your session in future also. I will also like to thank all the senior faculty members who have participated, especially Dr. Sangram sir, who has made this session very interesting by asking questions. Sir, we look forward for your support. And maybe in future, if you are willing, you can come forward and take some topic of your interest for the benefit of our students. I will also like to thank all the director, deans, and senior faculty members who have been supporting this program from the very beginning. And once again, I want to make an appeal that if you have any suggestion to make it better, and also you can suggest topics which we can take up in the future. So thank you so much. And especially the students who have joined us, all these recordings are available on our website. We have nearly 78 such video recording by eminent scientists from all over the country. And these recordings are available, and you can always download, or you can refer to NAMS website and repeat viewing these as long as possible. Another information for PG student is that we have a biostatistical helpline in collaboration with the Indian Council of Medical Research. So especially those PG students who are completing their thesis work and they require statistical helpline, they can just log into ICMR website or NAMS website, and they can book a time for interaction with our expert. We have expert both from ICMR as well as the National Academy of Medical Sciences. It is free, and they will be happy to help you related to your queries of thesis and some research studies if you have. Another information is on online program. We have 12 weeks online program in collaboration with the IIIT Hyderabad. This is on artificial intelligence in healthcare for healthcare professionals. This is orientation program, especially those young PG student and faculty members who are technology savvy. This program will be useful. We have completed 2 batches. In the first batch, we had nearly 140 persons who have been enrolled. In the second batch, we had 110. And the registration for the third batch is currently going on. So if you are interested for this particular program, you can refer to IIIT Hyderabad website or NAMS website, and you can register on that. The next session, online session is on this series is on scheduled on 21st of November, where again we are going to cover a very interesting topic of chronic disease management by Dr. Vivek Kumar from PGI Chandigarh. So please note that if you have any question related to this topic, you can send us and we'll share this question with the speaker. So once again, I'd like to thank Dr. Jaswant for helping us from the very beginning, for moderating and making all the efforts to be with us. So thank you so much. You have been very busy, but still you are able to be with us. We are grateful to you for your support. Here at NAMS, we have our IT team headed by Mr. Ravi, who has been helping us in organizing this program on Zoom as well on the YouTube and putting all these recording on the website, and Mr. Shivam, who is helping us. So once again, I thank all of you for making this evening very, very interesting. Special thanks to Madam for a very, very interesting topic. Thank you so much. Over to you, Dr. Jasmine.
Yeah, thank you very much, sir. Thank you for providing me the opportunity. And also a special thanks to Astha Thakkar ma'am. Ma'am, it was indeed a wonderful session, ma'am. Thank you. Thank you very much, ma'am.
Thank you. Thank you. And best wishes for the festival season which you have. Happy Diwali and all.
Right. Right, sir. Happy Diwali, sir.
Thank you, sir. Thank you, Dr. Jaswant. Thank you, everyone.